My name is Chris Varichello. Excited to be here, excited to deliver this information to you. One other housekeeping item, I used the chat box to give us some questions. You have three really experienced tenotomy providers here. We've done over 3,000 cases combined. That's a lot, and we have a lot of experience and a lot of pearls. One of the big things that we want to deliver to you all today, and thanks for being here, is we want to make this a little less intimidating for you. There's nothing special about the three of us other than, we know our skills, we know how to use a needle and guide it to a place, and we know how to read ultrasound and diagnose tendinopathy, and we have a great interest and a passion in this field. I think us as sports medicine physicians, we are primed. We have the skill set, we have the musculoskeletal knowledge, we have the ultrasound training, we have the comfort, and we have the time and ability to really be the champions for these patients with chronic tendinopathy type pains. We've discussed, Dom and Nate and myself have discussed at length how these patients, if we're not treating them, no one else is treating them, and if they are, they're treating them ineffectively, either with ineffective treatments or non-evidence-based treatments or invasive treatments, or they're just not getting treatment at all, and they end up in pain management on chronic opioids or something like that. So this is a challenge to all of you to really kind of broaden your horizons and not be afraid of treating these tendon patients that we all see in our practice. So to start, the burden of tendinopathy is huge, a 5% prevalence in the general population. And anyone that has a sports medicine or orthopedic practice, or even a general practice, we see tendinopathy every day, multiple times a day, multiple times an hour, a lot of times. These are the patients that end up in our office. The previous treatments, we're talking about immobilization. Patients come in with sling immobilization, braces, things like that. They're modifying their activities, they're compensating, they're developing other problems because of their tendinopathy related pain. The old rest ice, compression and elevation, physical therapy, non-steroidals, corticosteroid injections, and repeat corticosteroid injections, and another corticosteroid injection, and another corticosteroid injection, all for a problem that just continues to come back. Shockwave therapy, needle fenestration, prolotherapy injections, orthobiologics, and eventual surgical referral that may or may not even end up in surgery, because a lot of times a lot of our orthopedic surgery colleagues don't know what to do or don't want to treat some of these tendon problems. And as I mentioned, as sports medicine physicians, we are the primed clinicians to deal with this. We have our clinical training in musculoskeletal medicine. We have great ultrasound training, and we have our interventional procedural skills. We're already good at guiding needles to locations, utilizing a minimally invasive tenotomy as an option for tendon pain and tendinopathy related pain is something that just comes naturally. It's a natural progression for us, and it's something that we're well primed to deal with. And as I mentioned earlier, it's a lot of our practice. Approximately 35 to 50% of our practice is going to be tendon related issues, tendinitis, and most of the time it's tendinosis by the time they see a specialist or they see one of us. And 10% or more of those patients are going to fail those above treatments that I just mentioned. They're going to be recalcitrant, and they're not considered ideal surgical candidates. And so Dom's going to be running point for us here. So Dom, go ahead and advance that slide. So what we're talking about when we're talking about treating tendinopathy related pain and tendinosis is this fine, aesthetically pleasing debridement tool from HydroCision. So, and the goal of this minimally invasive tenotomy is to reduce pain, enhance tendon function by resecting and removing the pathologic tendon tissue. And Dom will touch on this in a little bit, but really we're going to frame this in your mind as a treatment that maybe this isn't how you've thought about tendon related pain, but you'll see with ultrasound imaging how you can really identify that bad tendinosis in the area of degraded collagen that will be primed to be resected with this device, this TenJet device. So to start, we'll talk a little bit about minimally invasive tenotomy and fasciotomy for the foot and ankle. So our first case, and we're going to go through a couple cases, and you can kind of just kind of make your own differential diagnosis, and we'll come to the conclusion together. But we had a 45-year-old female with a 6-month history of right ankle pain on the medial inside part of her right ankle that was aggravated with basic activities. Her physical exam revealed some pronation excessively with her gait. On the medial aspect of her right ankle, she was tender to palpation. She had limited dorsiflexion, resisted ankle inversion caused her pain, and she had some pain with single leg heel raise. She came to me with a MRI, and you can see with this cross-sectional image or axial cut, you can see on the medial aspect there, she has a pretty angry medial tendon there, the posterior tibial tendon. And I say angry because it should be nice and circumferentially black. And as Dom can point out right there, there's some mixed echogenicity or mixed intensity signaling in this that kind of leads us to believe there's a problem with that tendon. You go to the next slide, and then we can confirm that with the mixed echogenicity ultrasound. We have the poorly, it's not homogeneous tissue there. And you can see the hypoechoic areas all throughout, scattered throughout that tendon there. And so our next case, 51-year-old male with posterior left heel pain for 2 years. A runner had to decrease mileage because of the pain. Worse with toe-off phase of gait and ascending stairs. Had tried NSAIDs, physical therapy, walking boot, no significant or lasting relief. And that's kind of a case or a history that we hear oftentimes in our office, right? All these patients come with having tried other things without significant or lasting relief. The physical exam, antalgic gait was favoring that left side, pain to palpation, mid-substance portion of the Achilles tendon, limited in plantar flexion, secondary to pain, and resisted plantar flexion caused some pain, and pain also with a single leg heel raise. And you'll notice a little theme here. So we have some sagittal axial cuts of a cross-sectional imaging here. And you can see a mid-substance Achilles that's thickened, angry looking, mixed intensity signal in the T1 and T2 weighted cuts. Here we have a positive arrow sign, as we always like to point that out. And then in the axial cut there, you see the mixed intensity with the bright white kind of signifying the damaged tendon tissue there. And on our ultrasound, our MSK ultrasound, you see thickened Achilles tendon with some mixed echogenicity, some hypoechoic tissue there. And on the axial and the cross-sectional imaging, same thing as well. And then our third case, 41-year-old male with pain at the bottom of the right foot for 2 years. Worse first thing in the morning, improves after getting warmed up. Tried OTC remedies without relief, NSAIDs, and activity modification as well. Came to me with 4 corticosteroid injections with waning benefit. First one lasted about 6 months, second one about 3 months, third one about 1 month, and then the last one was about a week or so of benefit. Felt great with the corticosteroid, but wasn't about to come and get injections once a week for the rest of his life. Physical exam, was ambulating with excessive supination on the right. Basically because he was modifying his gait because it hurt to walk on his heel and the heel toe. Pain to palpation on the proximal medial calc, and a range of motion to muscle strength was within normal limits. And we have our cross-sectional imaging, our T2 sagittal cut. Dom can kind of point out the area of elevated intensity at the insertion on the calcaneus there, and then you have associated bony projection off the calcaneus as well. Which, as you can see on this MRI, that is not the problem. And I think we're going to touch on that a little bit. But this patient was obsessed with his heel spur, quote unquote, his heel spur. We had a lengthy discussion about his pathology. And if you go to the ultrasound, we have a thickened plantar fascia tissue there. And the calcaneus you can see there. So our imaging with that case. Go ahead, Dom, you can get the next one. So differential diagnosis, and really I'm framing these cases. We went through those 3 cases kind of quickly, but we have a lot of information to cover. But really, you can think of all of these cases similarly in how we're going to diagnose and treat. We have the cross-sectional imaging, we have the ultrasound imaging as well. Our differential for this, tarsal tunnel syndrome, a little less likely with the last 2 cases. Posterior tibial tendinopathy, plantar fasciopathy, stress fracture always in the differential. We really ruled that out with the MRIs, and Achilles tendinopathy. And diagnosis, so our cross-sectional imaging and our ultrasound, consistent with, for the first case, posterior tibial tendinopathy without deformity. The second case, we have Achilles tendinopathy confirmed with our imaging and physical exam. And our third case, we have plantar fasciopathy. All of these were recalcitrant to the conservative treatments that were provided to them. So really, this is where we get into the meat and potatoes of what we're going to talk about. So what are the options, and what do we have available to us, and what else can we do as sports medicine physicians? And let me tell you, there's a lot we can do. We can actually fix these problems and treat these patients, keep them in-house, and get them better. But the options are, generally corticosteroid injections. Obviously, you don't want to do that into the mid-substance of the Achilles. That would not be good. But plantar fascia, you saw that patient had 4 injections. That's not uncommon. Posterior tib, a lot of times physicians will inject corticosteroid peritendinously around the posterior tib. Orthobiologic injections, a role for those. Prolotherapy, PRP, stem cells. You saw some of that tissue though. That's a big ask for a lot of those treatments to really correct the pathologic tissue that is really driving these problems that we saw in these cases. Continued physical therapy, that's an option. A lot of times patients have exhausted physical therapy, or they are exhausted going to physical therapy. They've done it a lot. They've done it for weeks. They've done it for months without significant benefit. Surgical referral, options as well. Tenosynovectomy for the posterior tib without the deformity. FHL transfer for the Achilles that's damaged, plantar fascia release, et cetera, whatever other iteration of surgery for these problems. That's legitimate options, but what I really would like to talk about is something that we could do. We could do more with these patients. We don't just have to inject them. We don't just have to continue sending them to physical therapy. We don't just have to refer them to our surgical colleagues. We can treat these patients with minimally invasive tenotomy and fasciotomy. We have the skills. It's an ultrasound-based treatment. It's a precise treatment. And this is something we can do, either in a procedure center under local anesthetic for definitive treatment for these problems. So all of these patients I treated with minimally invasive tenotomy and fasciotomy for the plantar fascia. So for the posterior tibial tendon, the Achilles tendon, and the plantar fascia, that was our treatment of choice after a discussion. These procedures, like I mentioned, local anesthetic. Sometimes you can add a regional block if you wish, but local anesthetic. And each of them, I ran approximately a debridement of about 3 or so minutes for each of these. And the post-procedure rehabilitation is something that's really low key and something that patients really opt for when you deliver the treatment options and the recovery time. So for our patients, we did 2 weeks of for comfort a tall cam boot for the plantar fascia, for the Achilles, and the posterior tib. Walking long distances, I really encourage them to do that for the first 2 weeks. In particular for the posterior tib tenotomy that I performed, I transitioned those patients to ASO at weeks 2 through 6, and activity as tolerated after week 2 is kind of, I asked them to progressively load and stress the tendon a little bit and see how they're recovering. We did implement a home exercise program for these patients at week 2 as kind of my protocol at 2 weeks, focusing on ankle stabilizers and proprioception for the posterior tib. And 6 weeks post-procedure, most patients are pain-free or close to pain-free at that point, and then discontinuing the ankle stabilizing orthotic at that 6-week post-op appointment. So really what I want you to think of when you think of these problems, you see these problems, you diagnose these problems, you can funnel them into a common treatment algorithm where you see these patients, you see these issues with tendon and tendon attachment and hypoechoic and degenerative tendon tissue, and can really treat them the same way with this minimally invasive tenotomy. And you don't just have to keep injecting corticosteroid. You don't have to continue to send them to therapy, and you don't have to refer them out of house or to our surgical colleagues, because this is something we are well equipped to treat. Our training is good for this problem, and we can resolve this and keep patients out of the operating room or out of pain management. And so with that, we'll turn it over to Dom to talk a little bit about the shoulder and the elbow.
So thanks, Chris. And yeah, Chris does such a nice job setting the stage for these kind of conversations. And a lot of what you're going to hear is variations on the theme from him, myself, and Nate for the experiences that we've had. And as you can hear from the content of this isn't, we're not talking about the procedure as much as we're talking about the way to care for this patient. This is a population of patients that we all see. And these conditions for a long time, I think, saw us more than we saw them because we didn't have a great opportunity to treat comprehensively the tendinosis that was causing the issue at the underlying this. So I'm going to move to talking about the shoulder and the elbow, but start with a little expansion on what Chris was talking about of how we identify the right patients for these procedures and the types of patients that we see under ultrasound. So with the survey that was put out before this presentation, many of you noted that you've had experience with ultrasound. From a common extensor tendinopathy standpoint, this probably makes a lot of sense to many of you who are looking at it. So lateral epicondyle is here, radial head here, radiocapitellar joint. And then your common extensor tendon. So we see tendons very easily under ultrasound, much better than an MRI to really delineate the different layers and being able to see the fascia over the top. And then there's different features that we're able to pick up pretty easily. So if you have an ultrasound that you can show power Doppler, you can see neovascularization very easily within a tendon. And just the opposite of that, if there's not a significant amount of hyperemia, but a patient has that focal area, that focal hypoechogenic focus, that denotes tendinosis, that chronic degenerative, more thickened mucousy type of tendon that just can load way too much because it's so soft. And then having each one of those features present, both hyperemia and tendinosis. And we see these patients, they tell us what their symptoms are. The patients who, as soon as they start working out, they feel better. So they're a little bit stiff, and then they really start to open up. They loosen up. They like more motion. That's that tendinosis. That's a tendinosis that's almost stuck when it starts, and then it moves better. Versus somebody who, the more they load, the more blood flow comes through these small little tenuous blood vessels, and then they hurt more as they use their tendon. So their patients have been talking to us for years about that. Now we actually have a way of being able to see this. One of the questions we asked ourselves was, is there any reliability in seeing these features? So we published an article in 2021 looking at the inter and inter-rater reliability of hypoechogenicity, hyperemia. There were several different features. And the big takeaway is we looked between musculoskeletal radiologists, seasoned sports medicine docs, and then fellows, or sports medicine fellows. And it was highly reliable and accurate to identify both hyperemia and tendinosis across all readers. And this makes sense because it is very qualitative to be able to see all of these features. So we took that, and in a way to explain, well, what's actually going on with these tendons. This isn't a continuum, this is more subtypes, but if you look at the left and say, if you took a cross-sectional area across this tendon, and these were all healthy type 1 collagen fibers, they're densely packed together, and linearly they can load. As you get some more neovascularization and you're overloading this tendon, you're sending a signal that there is something that needs to be repaired. You get an increased expression of VEGF and different growth factors, and you end up growing these blood vessels in there. You're starting to displace some of those type 1 collagen fibers. You're starting to get swelling into the tendon. After chronic rounds of inflammation and likely some underlying genetics that we may not fully understand yet, you get this deposition of a different type of collagen, different type of substance that's softer. It does the job of taking up space, but that's just exactly what it does. It takes up space and it displaces more of your healthy collagen. And then you get to the point where you have a mix of all of these, and you can even separate some of these collagen fibers linearly apart from each other. And this is what we'd call a longitudinal split tear. So putting this classification together, it makes it really easy for us to say, hey, number 1 type of tendon, a type 1 tendon is a normal tendon because it doesn't have any hyperemia or tendinosis. The more inflammatory, or the ones that have more expression of what ends up feeling more painful with neovascularization, would be a type 2 tendon. A type 3 tendon being a degenerative tendon, straightforward tendinosis without the predominance of hyperemia, and then a combined tendon. This is one way for us to start talking about different types of tendon and how we approach them differently. And we're happy at the end of this to talk about how we approach some of these different tendons with other modalities. But these last two, this is what we treat with minimally invasive tenotomy, because as Chris mentioned, the purpose of using this device is to resect and remove this softer degenerative type of tendinosis so that you can decompress that tendon, allow it to heal back down so you can linearly load it again. So for the shoulder, one of the places where we use this very often is for calcific tendinopathy. So you got a 45-year-old woman with 3-month history, severe shoulder pain, 2-year history of some moderate on and off shoulder pain. Impingement signs are positive. Lacks that last kind of 60 degrees of active and passive shoulder abduction, because as soon as she gets into an impingement motion, she ends up hurting. Doesn't have any findings of adhesive capsulitis, no shoulder dysfunction, no radiculopathy concerns. Tried oral anti-inflammatories, physical therapy. She had 2 corticosteroid injections. One was landmark, the other one was ultrasound guided. She had an ultrasound guided 18 gauge barbotage, kind of 2-needle barbotage, and she was sent over to us for an evaluation. So in the past, we would have sent this to surgery, and we can talk about, removing a calcium deposit like that. You're going to end up leaving a fairly large hole to get to there if you did an arthroscopic surgery. After TenJet, immediately after, this is 2 minutes after the procedure, it's gone. And the neat thing about this is not only in just the rotator cuff or supraspinatus where you see it, in places where it's even a little bit harder. So this is a subscap. So you're looking at this in transverse to the humerus, long axis to the subscap here, and you can see the calcium deposit come into view. So that's this over on the left side. We'll try to mute it here. There you go. The procedure being done here into the calcium deposit. This is your view of the calcium coming all the way across, all the way over the top of the bicipital groove. And then again, immediately post-procedure. Another patient with large calcium deposit that you can actually see is causing depression of the humeral head. She was getting some inferior glenohumeral wear here. She started getting these small little spurs, this inferior glenoid osteophyte that's here immediately post-procedure. And the coolest thing about this, and Nate speaks about this and probably will as well, is how effective this is at removing calcium. So as a resection and a removal device, patients see themselves get better. We normally let this sit and you can actually see it collect in the bottom of the device for patients. And in the same way that we approach the shoulder for calcium deposit and for tendinosis, for thickened bursa. This is the bread and butter of a lot of what most people start out with, is treating common extensor tendinopathy and common flexor tendinopathy. We see both of these very often. 42-year-old guy comes in, 6-month history, severe, atraumatic, non-radicular type of lateral elbow pain or medial elbow pain. Took an oral anti-inflammatory, same kind of thing. Has had a couple different injections. And in the past, what we do, they might get another injection. We might try a couple other physical therapy modalities. Certainly, if they haven't tried some hands-on manual therapy, instrument-assisted soft tissue mobilization, there's certainly some evidence that's out there. But when they get to the point where it's this chronic, they have a tendon debridement right open, or have a tendon release. It was done quite often for many years. And for us, going in from a procedure standpoint, being able to see that we're not only treating the tendon, but also just part of the procedure, and we can talk about this more during the panel, is the hydrodissection, right? A lot of these patients have had this pain for so long that the fascia over the top becomes so inflamed and so thickened, it actually adheres down to the tendon. And there's a lot of neural fibers inside that fascia that can cause a lot of pain. So we get an opportunity of treating the fascial scarring over the top. This is the anesthesia of the procedure. So very small little aliquots. We're injecting, less than probably 1/8 of a cc every time we're drawing back as we're anesthetizing it. And then after we've fully anesthetized there, we get an opportunity again, making sure that we're completing a hydrodissection of that fascia. And then for the procedure, again, very easy to perform. If you can get a needle to the tendon and inside a tendon, you can perform this procedure because it's the same thing, but you're depressing a pedal. The skill and the experience comes in really the feel of the procedure and what you're noting when you do the anesthetic, feeling the softness, the tissue texture change of tendinosis versus normal tendinopathy. And for this tendon, it's very easy to plunge into that tendon. Normal tendon shouldn't be that easy. They should be really dense, regular connective tissue, right? But this, having a tendon that has this much tendinosis, is very easy, as you can see, just kind of plunging in there. The other opportunity we get with this is also to kind of scrape along the tendon where a lot of those small little neural fibers from the fascia can exist. So it's a very comprehensive approach from a minimally invasive standpoint, which is very few things in musculoskeletal medicine and orthopedics that has that combination of both, with something that doesn't require the patient to be significantly sedated, no hospital stays or anything like that. So from a post-procedure rehabilitation standpoint, how do these patients do? You know, like as Chris said, as you start treating patients like this, they start to group into having some very similar journeys afterwards. So first thing we do, we don't do any slings. We get them moving very quickly. And the most important thing is we don't use any slings. So all of those patients with calcium deposits of the shoulder, they're actively moving their shoulder, and we'll have them, as soon as we're done, we put on steri strips and wound dressing. We have them raise their arm, and they're shocked because they're like, oh, maybe I shouldn't. And as soon as they raise their arm and they had a big calcium deposit and they already feel better, great. We talked to them about that's the anesthetic, but it's also because the calcium deposit's gone. And the same thing for the elbow. We will put them in a neutral wrist brace for 5 days with common extensor, common flexor tendinopathy, just so they remind themselves that they had something done, so they don't go grabbing, shaking people's hands or turning doorknobs too hard. But within the first week, we're getting them back to at least non-impact kind of repetitive activity. As their pain allows, try to get them less than 5 pounds, less than 10 pounds a second week. And they're starting back to progressive loading therapy program at week 3. They can do maybe a little bit of some isometrics, isotonics, a little bit of maybe heavy load isotonics and isometrics at the second week, but they're getting back in pretty quickly to use. And then normally we'll follow up at 8 weeks just through our EHR messaging. For anybody who's struggling or having a little bit of trouble, or most of the time if they're pushing it too much, at 8 weeks and they go, what did you do to my elbow? We'll say, well, what'd you do to your elbow? And they'll say, well, I've been pushing a little bit. It felt really good for the first couple of weeks. The great thing is the downside, the most significant side effect to this procedure, if they're going to have an adverse effect, I mean, your infection risk is incredibly low. It's going to be tendinitis, right? They're going to load it too much, too quick because it feels good. And we can deal with those, but you can also prevent it just by giving them a nice progressive loading program. So safe procedure, easy to do, takes full advantage of the complement of the skills we have. If you're talking about being a top of licensed sports medicine physician in this day and age with what the requirements are for ACGME training, this is where we are. And this is a place, and the great thing, it's a place with patients that do not have any other treatment options. There is a gap of treatment for tendinopathy that is filled with a sports medicine physician. And we've been happy to add this to our repertoire. And I've been honored to be in contact with these two guys for a couple of years, because we've all learned from each other. And I think all of our practices in the way that we've approached TenJet has changed over the years, just with the collaboration that we've had. So thanks for your time, and we'll hand this over to Nate to talk about MIT for the hip.
Hi, everybody. Nate Holmes. A little bit different background than these guys. I work in a private practice orthopedic office, large group. And so, I'm not standalone sports medicine doc. I'm doing, full spectrum orthopedics, but really filling in the gaps where my partners don't. And so I've been able to see our utility here with this procedure and get absolute buy-in from our orthopedic partners when we're treating and fixing things that they don't like to or traditionally treat well. And hip is a great opportunity to talk about that, because they don't have great options for some of the stuff we're going to talk about, and we really have a chance to affect quality of life substantially. This is my absolute favorite thing to do. Dom talks about elbows because everybody likes to start with elbows, and the approach is easy, and they do great, and they're pretty consistent. But to me, this is old reliable. This is consistently helping people dramatically change their life by treating chronic hip pain. So I like to start with talking about the first patient that I ever treated with TenJet. 55-year-old woman walked in my office. I'm working in an orthopedic office at this time. She's got 15 years of on and off recalcitrant lateral hip pain. It's one of these ladies that for at least 10 years has been getting corticosteroid injections semi-regularly. Same story as Dom. Starts out 6 months of relief every shot, 3 months of relief. Recently I'm getting 2 weeks of injections, but the doc who's treating me tell me there's nothing else they can do for me. So I continue to get them and then suffer until I'm allowed to have my next injection. 3 separate courses of PT with limited improvement, has looked for everything, right? Has failed shockwave therapy provided by somebody else. Got an iliotibial band release from one of my partners that didn't help her. Had 2 or 3 PRP injections from another provider that gave her temporary slight improvement and came right back. Had a previous MRI that was read as unremarkable, tendons intact, no substantial tearing. I threw a diagnostic ultrasound in the office, and you see imaging of a greater trochanteric area, the glute medius with obvious tendinopathy evident on the ultrasound exam. So, I mean, this is a little bit earlier in my career, and I was not excited to inherit this lady, right? Because you're thinking, what am I going to do with this woman? How am I going to get her better? And at the time, I'm looking at it thinking, I've exhausted all my options. What else do I have? And that's when I started thinking about minimally invasive tenotomy. Her results were phenomenal. 2 weeks post-procedure, she told me, she walked in the office and said she wanted to kiss me on the lips, and attempted to. Pain was reduced by 90%, complained of a little stiffness, slept through the night for the first time in 3 years. And I started to think to myself, okay, maybe there's something to this. I mean, this is a woman that has tried everything and not gotten better. And relatively easily, I was able to get her better. By 6 weeks post-op, she was completely pain-free. We're talking years ago of this case. I still see her for random orthopedic issues that come up. I've seen her in the last couple of months for an unrelated problem, still pain-free. I told her I was going to talk about her in this talk, as I often do. Offered for me to take her picture, offered to join us and tell everybody how well she did. Just an ecstatic patient. So, this got me started. And I think the take-home point from this patient is MRI availability to diagnose gluteal tendinopathy, MRI ability to look at a tendon is not the end-all be-all here. And our ultrasound skill is really going to come along with helping diagnose patients and treat patients. Dom, if you can advance the slide. So how did I used to treat tendinopathy? Chris has touched on this, Dom has touched on this, and you're going to hear similar themes because we've all done it and we're all doing it, right? I send patients to therapy. I try to correct biomechanical abnormalities. We see them. I think that's still important. That still has a role in what we're doing. I give them a steroid injection. I'd give them another steroid injection. I would get in that grind of, all right, well, I'll see you next time this comes back. I send patients for manual therapy and try another steroid injection. I was an early adopter of just ultrasound guided percutaneous needle fenestration tenotomy, right? I'd get in there and, for lack of a better terminology, I just needle the heck out of it. I try to do what I could to disrupt that tissue and induce some healing. Sometimes successfully, sometimes less successfully, but I'd cause a decent amount of post-procedure pain in that scenario. I use orthobiologics. We can talk about it. There's certainly data and a role for PRP as isolated treatment for tendinopathy at times. And at times I would give up and talk to my surgical consults or surgical partners about what they could do. In the last day, I had a conversation with, I previously worked with an orthopedic surgeon who's now probably about 70, who's still referring me patients for tenotomies, despite not working together anymore. And my conversation with him was really, he would do trochanteric bursal resections and IT band releases. And it was, okay, well, when you get in there, what are you doing to this tissue? What are you doing to try to make this person better? And the response really was I just get in there and muck around a little bit, try to disrupt some tissue and close it back up and call it a day. And sometimes they get better, sometimes they don't. But not really being able to identify, like we can with ultrasound, that pathologic tissue to make a change for this patient. You can move forward. Now, how do I treat tendinopathy? I still believe in physical therapy. I'll still use it as a first-line agent. I can still be talked into corticosteroid injections. If I've got an acute patient that I'm finding is falling into Dom's stage 1 disease there, we can talk about steroid injections. Oftentimes I'll use a steroid injection to bridge them to what I really want to do, which is a TENJET for them. And sometimes biologics, sometimes not biologics. But as the more I do this, the more this is fixing people and I'm not needing to use orthobiologics as a treatment option. But it's really moved up my algorithm significantly. Now, when I'll talk to a patient who comes in, somebody's had 3 years of lateral hip pain, the conversation doesn't revolve around, hey, let's give you an injection and calm it down and see if we can rehab you some. The conversation is, what's the pathology that we're treating? What's really causing you to have pain for 3 years? And how can we fix that pathology? And I think the take-home message here, particularly in hips, is trochanteric bursitis is not typically the diagnosis for lateral hip pain, especially somebody that's had recurrent or chronic lateral hip pain. There's good evidence to say that if you image these people, MRI imaging, ultrasound imaging, less than 10 or 20% of them are going to have true bursal enlargement on imaging studies. While it's the terminology that we're all taught, while it's the terminology that we're comfortable with, it's not really the pathology. both ultrasound and MRI data to say gluteal tendinopathy is the most likely cause of patients presenting with lateral hip pain and tenderness of their greater trochanter. Patients with isolated trochanteric bursitis are treated by their primaries with NSAIDs. They will sometimes calm down and do better. But by the time we've got recurrent pain, by the time we've got pain that's lasting multi-months, there's some degree of tissue disease that needs to be addressed to fix the problem. Treating chronic tendon pain as acute inflammation at best pushes it down the road, right? We're waiting for the patient to come back and their pain's back, and it doesn't address the real pathology. And recurrent corticosteroid injections certainly carry a risk and have a downside to tissue. The incidence of trochanteric pain is at least 2 out of 1,000 in primary care doc studies. At a year, over a third of those patients are going to still be suffering from trochanteric pain. And there's good data to support that probably 30% of them 5 years later, if left inappropriately treated, will continue to have chronic pain. And these are the patients that I worry about, right? These are the patients that, as Chris was alluding to, once they run the gamut of injections and physical therapy, they're either going to search for cash-based businesses that have some role, but probably more difficult role in fixing this, or somebody's going to give up on them, right? They'll find a surgeon who's going to intervene with a procedure that doesn't have a great success rate, or they won't. And then they'll end up saying, okay, you've got severe pain. Let me give you some narcotics because I'm sick of you calling because you can't sleep. And then somebody will go, okay, I can't continue to give you chronic narcotics. And then they end up in medical pain management. And now we've got patients that are chronically taking narcotics for a very fixable, very curable tendon pain. And this is where I think we sometimes really need to up how we're treating this problem. Certainly, trochanteric pain exists in a similar calcific tendinopathy. This is a patient that I treat, a little bit different angulation of the x-ray, but decently sized calcification right in the gluteal tendon, right at the greater trochanter. My x-ray is not quite as quick as Dom's treatment because I'm not necessarily x-raying the meat after, but 2-week post-procedure x-ray on the right, which is when I usually do them, completely removable. And these are great. I love seeing these because 2 days, right? I mean, a little bit of inflammatory response sometimes from the procedure, but these people are back great immediately, almost immediate improvement. These get under great tension. Those big ones that Dom was showing in the rotator cuff, similarly, they are under massive tension. You can see on his x-ray pushing the humeral head down. You go in and put a little local in them, and I'll often find you put the device into that calcification. I won't even step on the pedal, and it's under so much tension, you can see the calcification just burst into the tube and sitting there. And it evacuates it quickly, very safely, no damage to the surrounding tendon. If you send this to an orthopedic surgeon to remove this, they're going to create a huge void, a big area of tendon damage, and they're going to attempt to repair that. And I don't know what anybody else's experience with it, but I see them. I've seen a lot of them work in the role that I fill. Primary gluteal tendon repairs do not do well. There is not a significant, reliable improvement in them. Most docs don't like doing them because of that. We'll see the tears that they create, right? But when I image these, I don't get scared of things that are in the spectrum of tendinopathy, right? When I see somebody with interstitial tearing, when I see somebody with partial thickness tearing, and Dom's great to talk about this as well with some of the slides he's already shown, those are spectrum of tendinopathy disease. You don't need to be afraid of them. They are treated the same way. They do just as well. We know that this device does not cause damage to healthy tissue. So you don't have to worry about, oh, am I making a bigger tear? Am I making a bigger problem with this? You're going to be actually fixing the problem by doing that. So my gluteal tendinopathy approach, most frequently glute medius, but you'll see glute minimus. I think you see them both concurrently at times. I like to come in plane, put the patient in a lateral recumbent position with the knees flexed. I most commonly come in a long axis in plane with the tendon from posterior to anterior. Just like Don was touching on, I think it's very important to hydrodissect the tissue with local needling around a little bit to anesthetize the tendon as I go. That'll help you delineate those abnormal tactile feedback areas from the normal ones. You can see them on ultrasound, and then you can really feel them tactily. Minimal incision. The more I do this, the smaller the incision gets. It's essentially a small poke through the portal. And then inserting the device. I can cover the whole thing up with a single steri strip. Ours come in 3s, so I put 3 on it because I've got 3 to make myself feel better, but a single steri strip will cover it up. Post-procedurally, there's some discussion about non-weight bearing status versus weight bearing status, and we'll have it often. I let them fly immediately. I try to get people on them as quickly as possible. Strength loss from crutches, it causes considerable difficulty. I'm not worried about somebody loading and rupturing their gluteal tendon after doing this. I tell them, walk for life, right? Do the things that you need to do day-to-day life, get moving. I don't have them walk for exercise. I don't have them exercise in the first 2 weeks. I protect them in stair use. I mean, you're going to significantly activate that gluteal musculature going up and down stairs. And so we give them protected stair use. Weeks 2 to 6, I started in posterior core rehab, often just a home exercise program, and formal physical therapy if they're having difficulty activating their glute. Return to work, full labor jobs and sports activity, usually by 6 weeks. As Chris was indicating, 6 weeks in, people are coming back saying, I feel great, I've got minimal soreness and stiffness. I see progressive improvement, though, in folks up to 16 or 20 weeks post-procedure. And during that period of time, I'm continuing to address their abnormal biomechanics. I mean, this develops in people with poor posterior core strength. So we want to address that. We want to address that so they don't continue to overload that tendon afterwards. Second case I came up with is another extremely common case. 35-year-old avid runner, 5 years of progressive proximal hamstring pain running and sitting after exercise, failed a blind corticosteroid injection by another provider, minimal improvement with 16 weeks of formal physical therapy. Had an MRI study showing hamstring tendinopathy with a small insertional partial thickness tear, edema that you can see in the below image at the ischial tuberosity, very common presentation. Went right to hamstring tenotomy for this patient in this scenario. They failed physical therapy. They had a corticosteroid injection. Positioning is exactly the same. Lateral recumbent position. I formally did them supine, and a big conversation with Dom has changed my practice and approach, and this is where I think we learn from each other a lot. Doing them supine, you're fighting with yourself, trying to come in plane with the tendon in long axis to get yourself the clearance to get in at the ischial tuberosity. Coming proximal to distal in that recumbent position, much easier, much less ergonomic stress on yourself, and better to localize where you're at. The caveat here is, and I always tell patients, these take longer to get better. Your hamstrings under tension, they have some trouble sitting initially. You'll get some irritation. I often offer them a cushion for sitting the first couple of weeks. Similarly, I wouldn't argue with somebody that made these folks non-weight bearing for a week or two to take off the tension on the hamstring, but I let them walk immediately. I try to get them mobilized, get them moving. I start physical therapy 4 to 6 weeks out on these, starting with eccentric focused therapy. Return to work, usually 8 to 10 weeks, in sports, 12 to 16 weeks. More painful post-procedure compared to a lateral hip, a little bit longer recovery time, but excellent prognosis. As I previously indicated, this patient had a partial thickness tear at the insertion, did great, did phenomenally, no issues with concerns of progression of that disease or staying away from it because of tearing evident. We can move forward. There's a slide indicating the approaches that we'll take. On the left, for gluteal tendinopathy, the most common approach is right in plane with that glute medius, doing the entire procedure in long axis. Really easy to localize, really easy to see what you're doing. You can come from distal to proximal, and I'll utilize the second approach here that we're seeing. Somebody's got significant iliotibial band issues. If they've got a lot of tightness in the iliotibial band and I want to work that concomitantly, I think it's a little bit easier to take that approach. I've had patients where I've used both approach. And you can see the hamstring tendinopathy approach is the exact same patient position, but I'm orienting the probe in line with that ischial tuberosity, and we're actually making our approach from proximal to distal, which, at first I thought made less sense, right? But all the disease is always typically right around that ischial tuberosity. It's easy to come in right over top of it. You don't lose yourself ergonomically with trying to fight with your own hand and that patient's leg as they are when they're supine. You can really use, this is another scenario, we can really use that tissue hydrodissection to delineate the tissue layers that you want to work on. And this actually has made my life a lot easier utilizing this approach. And it's sort of a pro tip I got from another pro, and very, very helpful. We'll move on, Dom. Can you advance the slide, Dom? So what I really want to focus on, take home here, is this: that we want to treat the tendon pain algorithm differently, right? We want to treat the pathology, not the. Go ahead. We want to treat the pathology, not the downstream symptoms. Think about fixing the tendon tissue issues and not just kind of covering up the pain. Minimal life disruption with this technique, safe, easy, long-term solution to tendon pain, at the same time addressing biomechanical contributing factors. Yeah, one more slide here, Dom. No, we don't. I do want to just address quickly. This has significantly moved up my tendon treatment algorithm, right? It has. I started with that. Let me treat the pain. Let me treat the pain. Let me address the biomechanics. And I think if you're not addressing the intrinsic pathology of this tendon to correct the problem earlier in your treatment algorithm, you're just delaying the inevitable. So I start having this conversation early. First time I see somebody, even if I'm going to inject them, I have the conversation about there's likely a bigger picture tendon pathology issue, and if we want to get better and stay better, we're going to need to address that. So I think there's a lot of questions that have come in, and if nobody has objection, we'll move on to that at this point. And I'll kind of there's several repeated questions here, a lot of this similar themes. So I'll just kind of condense a couple of them and sort of pass them around here. A decent amount of questions surrounding both partial and near full thickness tendon tears, safeness of the device, utilizing that area, and treating enthesophytes or concerns for treating enthesophytes with this. And Dom, if you want to address that, I think that'd be a perfect question for you.
Yeah, it's fair. I think with tendon tears, and there's a couple videos we have there. As Nate had said early on, you almost think about, should we be getting into some of these areas that are torn? And then once you realize that, hey, this is just another part of the tendon that's not as functional. If you have a big, significant, greater than 80% partial thickness tear, and there's almost nothing holding on, it's probably not going to be the most effective tool. But for something like this patient came in 2017, common extensor tendon. The superior portion of it is attached, but then kind of almost peeled off like radiocollateral ligament here, and then into the insertion along that slope of the lateral epicondyle. Large, big tear, pretty significant. Patient came back in 2 years later for just some flare up. He had a little hyperemia here and had recurrence of some tendinitis, and we couldn't find the tear. And so we even looked at cine loop videos, the TOPS 2017. And you can see this tear kind of coming in and out here as well, panning across the area, little focal area tendinosis that's a little bit deeper, but the tear is gone, right? And so the thing is, we wouldn't go and claim that this is something that's going to heal tears, but if you think about what a tear is area of tendon that is no longer laminarly adhered to itself. If you go in and remove the areas of tendinosis that are there, you're causing a small little local inflammatory effect. Are you causing that to scar back down? And that's appropriate scar. It's reapproximating the laminar layers of the tendon to the point that they can load again. And so it was after this, and then meeting these guys and talking to them about tears, and they said the same kind of thing. And if there's structural integrity kind of around the whole outside of the donut, and the inside of it is what is torn, and it's these longitudinal split tears or some of these deeper partial thickness tears, or even up to maybe up 50%. That there's some closed off area that you can still get that kind of laminar adhesion, it's worth doing. Certainly right at the area of the enthesis. And then for enthesophytes, as Chris brought up a great point, talking about the heel spur, right? It's not a pain producing lesion if there's not, especially if there's not edema on an MRI. It's the tendon that's within it. So I'll throw that over to Chris, because he speaks to this really nicely about how large some of those spurs are and how worried patients get about it, and having that conversation with them, that's not where your pain is.
Yeah, and thanks, Tom. I'll echo that. People get obsessed or really interested in their heel spur, and I think claiming the heel spur is the pathologic generating factor is incorrect. It's actually the tissue that's attaching in and around the area. So and that's coming from experience. That's coming from looking at MRI and ultrasound imaging. You can identify the tendon tissue that may be close in proximity to the enthesophyte or the spur that is pathologic, but not actually the bone itself or the enthesophyte that is where the pathology lies. And so from my experience, you can leave that alone and you can debride the tissue surrounding that, or that's in a very close proximity, and still get the patient better. And so that kind of all adds to my experience. And I think Dom and Nate would echo the same thing. You don't need to take care of the spur. And sometimes I've gone as far as roll the dice and take an x-ray of the opposite foot, and that's not causing a patient pain. I say, look, you have a matching spur on the other side, and that foot does not bother you. And that's, I'm rolling the dice and making sure, hoping they have that. But oftentimes when I've done that, that's the convincing factor. And now I can really speak from experience as well, just from doing that. You debride the tissue. The soft tissue is the problem, not the hard tissue.
Great. A question about a certain period of time waiting after a corticosteroid injection to do TenJet. If it increases the risk of post-TenJet infections or rupture. Tendons that I'm worried about rupturing that are in a constant load like Achilles, I'm not willing to inject with corticosteroid anyway. I've had this conversation with some of my surgical colleagues about the steroid and infection risk. They have some decent data surrounding knee arthroscopy and risk of infection. The general consensus is week or two, right? Let them flush it out of their system a little bit and it's safe. I'm not afraid of it in any way. I mean, when I would do, just like when I used to do a barbotage, when I would do a TenJet of a big calcification in the shoulder, I would often inject some steroid in there at time of, right, to try to help with some post-procedure pain. I don't do that anymore. I think getting it out immediately makes them better. But I don't think there's any significant risk or concern there. And I'm often using a steroid injection to bridge them for some pain relief until I can actually fix their problem, because unfortunately, more of us need to be doing these, and we get booked up way out because we're a lot of the folks in the community who are actually doing this to fix the problem, and it becomes pretty popular. Somebody asked about length of time to start a pain to start thinking about doing TenJet. I don't think there's a time course. I usually see patients when they've got months of pain already, and that 3 months or so bridge to developing tendinopathy. You can see it, right? This is again do an ultrasound exam. You'll see if there's tendinopathy, and if they've got tendinopathy, they've progressed into those later stages that you're seeing on Dom's slides. It doesn't matter to me if they've had 3 months of pain, 3 years of pain, or 3 decades of pain. They're an appropriate patient for treating with TenJet. There was
Nate, I think you make a good point about that too. I'm at a large institution where when you talk about safety and quality, everybody's got an opinion on it too, right? So I think for that, I agree with you in terms of a lot of these sometimes within a couple of weeks. Our protocol is 8 weeks from injection to procedure, and I think this is a good point that we continue to kind of have these discussions as well, because sometimes it's where your practice is what's going to do it. The benefit I like about 8 weeks, to what Nate said, when you start doing these and you have colleagues who are sending them over to you, it's going to be hard for you to do the procedure the same week or the next week. You are going to be booked out with these. And so 8 weeks is perfect, right? Because it's enough time to see if it worked, but it's also enough time to get them on the schedule. So that's it's a protocol that I think has worked.
I think, Dom, you kind of led to a question, and I'm just seeing here, and sorry to jump in, Nate, but volume. You can kind of lead to that. I don't have a protocol for corticosteroids. I'm booked out about 5 months with my procedures right now, and that's doing about 30 to 40 of these a month. So I do a lot. I do a lot of them. I'm booked up with them. I'm doing the corticosteroid injection, and there's usually a length of time spanning in between. So that's volume and corticosteroid answer both. And I don't know if you guys want to speak to your volume as well.
Yeah. I'll do 200-300 of them a year. I similarly, not maybe quite as popular as Chris is, but I'm booking 2-3 months out at least. And so I'm not worried. There's nobody that I can do one in 2 weeks after a steroid injection anyway. It's not going to happen. but similar volume. I know that there's a quick question about where you guys are doing these, and leads to Dom's institutional discussion. You're doing them in the office, or you do them in ASC, or you do them at the hospital. And there's a mix here, right? So I'm doing all of mine at an ASC, where I have some ownership stake because I've done a lot of it in ASC, which is obviously a great thing for us as a subspecialty. I will offer my patients some max sedation if they want it. It's an offer. I'll do them under local. I'll do them both ways if they're hesitant or they would like to. I know you guys can discuss where you're doing them at.
Yeah, I'm doing it in an ASC that I do not have any financial interest in. So for good for Nate on that. But yeah, it's ASC is a certified procedure room that we have humidity controlled and negative pressure ventilation that's in it as well. In terms of volume, I agree. Very similar to the guys before I sold out and became an administrator, and so now 70% of my time I flipped out a white coat for a suit coat. But when I do them every other Friday, it's normally about eight to nine procedures on those Fridays. I was cranking at one time, but not anymore.
Yeah, and I'm also at an ASC that I do not have ownership stake in, unfortunately. In a procedure room, and I run 2 procedure rooms and kind of have them set about 25 minutes apart.
All right, and we're getting just repeated question after repeated question about 10x versus TenJet, and what do we think is safer? What do we think is better? What are the advantages versus disadvantages of 10x versus TenJet? And I can see Dom's already got some slides primed up that I'm sure he would like to address.
Well, I think we could all lean into this because we've all had our hands at using the devices. I started out with 10x, and as a device, you can use the entire sheath in the kind of the hosel that's here up to the needle device. So you have a longer device that's overall also a thinner from a gauge standpoint device. And it's the technology that's different, right? So if we go back to the thoughts around that tendinosis, you think of it as softer tissue that's around this harder tissue. The harder tissue is the healthy tissue, and then you have the softer tissue. You want to remove the softer tissue. How do you do that? 10x is an emulsification device. So it vibrates back and forth very quickly at the tip of it, and then it uses saline to kind of mix with the tendinosis and then suck it back in. So the aspiration happens after the injection of the saline. So you're kind of violently shaking the tendinosis and then sucking it back up. It can be effective at doing it. However, it's not actively resecting and removing. It's kind of emulsifying and then sucking it back up. And you can see just the power of suction that you have from the TenJet device allows it to actually be a resection and removal device. The other thing that the guys might talk to is I used to have patients have really swollen tissue. So swollen elbows after using 10x, and it's because it's not as effective of a tool of removing fluid. So I'll just play that again. It puts fluid in faster than it removes it. TenJet, it's using fluid to cut, resect, and remove. So it's a more efficient device. And that goes to the kind of the size here. It's ability of being selective. Somebody put in the chat, if you go up and you touch cortex of bone with TenJet, what's going to happen? Nothing's going to happen, right? You have suction that's going to remove softer tissue because it's the amount of tissue that can fit through that size of the window. So if you made that window really big, you could take out a lot of different kind of tissue. It's small enough, and this is through several different rounds of getting that window the right size, to be able to remove the degenerative tissue without the healthier tissue. With TenJet, if it can get through the end of it, or 10x, if it can get through the end, I mean, you can bore into cortex with it, and that's kind of one of the benefits of one of their devices, the 10x bone, right, is being able to get into cortex if you need it. But as we said, majority of enthesophytes aren't the pain-producing lesions anyways. That saline evacuation efficiency and the heat that would happen, you get about 3 minutes, I think, before it starts getting warm, because it's mechanically 2 metal pieces that are going back and forth. So the saline is not used necessarily as evacuation as much as it's to try to cool 2 pieces of metal that are sliding back and forth from each other, versus TenJet that doesn't get hot. And it's the multiple pieces in the sliding kind of friction between the metal that has led to some significant FDA MOUT events, the manufacturer and user facility device experience records of any serious injuries or device-associated malfunctions. To this point, at least into today, Elaine, I don't believe that there's been any MOUT events with TenJet. So I talk maybe more at length, but it probably answers a lot of the questions that are out there. I'll toss it back to Nate and Chris in terms of your experience with the other devices.
Yeah, I'll jump in.
Oh,
Go
sorry.
ahead, Chris.
Well, I was just going to jump in. I started as a 10X user about 8 or 9 or so years ago. And then the TenJet device was brought to me. And in addition to everything Dom said, just the how you're able to use the device is a little more flexible and precise. And so the I guess the usability or how user-friendly the device is, the length of the needle, the ability to manipulate the tip of the needle to get it into places that you need to get to, and then the cutting window, as you saw on one of the earlier slides that I showed with the saline. That cutting window can also be manipulated and turned, in different directions to expose the entire tendon tissue to the cutting window. I will often, piston and I'll rotate. I'll go superior and inferior and medial and lateral, and I'll sweep the device. And so I really like how user friendly and how easy the TenJet device is to use, and on top of all the other I guess the details of the size of the device and everything like that.
Yeah, I would echo what these guys said. Similarly, adopted from the previous experience, better manipulability, better able to remove tissue that I was looking for, better tissue selectivity. I don't know if anybody's ever done a lot of 10X, but taking a hold of somebody who's just leaking saline from their elbow after you've done one, and not having the experience of that heated needle tip in my hand. Really, if I can feel it, what's it doing thermally, and so that was some of the rationalization for my switch, and then just results. I mean, I've anecdotally had better results because of those reasons. I'm able to access tissue that I wasn't able to access with 10X. I'm able to get deeper into a hip. And somebody asked a question about, if you've got a heavier patient, this will let you get deeper. For sure, you'll be able to get at tissue pathology you couldn't get from a length perspective with a 10X device. And I know I was an adopter of 10X early and shifted to this because I can do more with it, and I seem to be able to do better work with it. Because again, the take home there is just even early on with 10X, it was the best thing I thought I could do to address the tissue issues. And for me, this is addressing those tissue issues in a better, safer, and more direct way. I think we hit the bulk of the questions. You guys seen anything that I missed?
I think the only other thing is, the question about orthobiologics, and I think it's, can probably go on a whole lecture about when not to use it. What I would say is I agree with Nate that there's some good evidence that's out there. The evidence that's out there, and in fact, if you really look at it, and even just anecdotally, that type 2 tendon, the one with hyperemia, is probably the one that responds best to leukocyte-rich PRP. And it's because if you think about how LR-PRP works, think of it like sclerotherapy for very tenuous blood vessels that are in your legs. You're scarring these very little blood vessels down. That hyperemia takes up space. It's flared up. It's angry. Those symptomatologically are the types of patients who get better from PRP. And it's probably because if you looked at a really good study that would be done, is the patients with hyperemia and type 1s and probably the type 4s that have hyperemia are the ones that respond. So at the same time, if you think a patient may need an orthobiologic augment, it's probably because they're going to have significant hyperemia prior to, or after you've treated it and they're loading it, just the overloading has now caused more hyperemia. So when you start to use more, if there's a lot of people who are out there who use orthobiologics for tendons, look at the patients who respond or don't respond in terms of how much hyperemia there are, and I bet you see a nice trend. Nate, Chris, I don't know if you see similar type of trends or that's how you approach it.
Yeah, that's been my experience as I've shifted more. Because of that, I've probably shifted away a little bit more from orthobiologic treatment as a primary and into more TenJet. I'm staging them now, similarly with ultrasound before I'm doing them and having that discussion about what's the success here, what are we really trying to do. I've got patients that want to go through getting to this and trying orthobiologic first. It's an open discussion with them about where I think they fall in the spectrum of disease and what I think is their most likely success ratio. And then there's a cost discussion, right? We've got a covered procedure that we're utilizing that works exceptionally well, and there's a cash-based product. And there are patients that will want to discuss paying for that, and there are a lot of patients that are hesitant to talk about cash-based treatment, especially if they've got covered procedural treatments that are highly successful and work very well. And for those reasons, it's taken over a lot of folks that I previously was offering orthobiologics to.
Yeah, I agree with that too. One of the things that you guys are picking up on, and kudos to you for asking the questions and being interested in this, is we're learning so much more about these problems. Like even 5 to 10 years ago, how educated we were on tendons and how to have these discussions, and why is PRP working in some scenarios, why is tenotomy working in other scenarios, why is corticosteroid working in a different scenario. Look at how far we've come and how far we continue to advance this. And we're able to have these educated conversations with patients and then deliver precise, appropriate treatments that are going to be successful. And this is the point of the whole lecture. We're the ones that this is our bag. This is what we do. This is where we fit into orthopedics and sports medicine. This is our specialty. And we need to take ownership of it, and we can take ownership of it. It's exciting. It's an exciting time to be in this specialty and doing this work and seeing these great outcomes. So it's a lot of fun and more to come.
And I think if you're seeing this and you've not been thinking about tendon disease as this spectrum that the DOM slides do a good job of showing, this is a really good opportunity to start taking a look at your patients and going, all right, what am I seeing here on the ultrasound? And putting the Doppler on them. Where am I seeing disease? Am I seeing hyperemia? What am I looking at? And then thinking about where you're at and what you're offering those patients. And if you really start to dig in to tendinopathy as a problem and ultrasound as utilization for diagnosing of it, you're going to really start to think about how you can expand your treatment options and work things up your algorithm and approach this in a slightly different way, in an easy way, right? If you start thinking about it, and most of us are doing diagnostic ultrasounds on our patients on a regular basis, you're going to see it. You're going to see things that look like these slides very quickly if you're looking for them, and have a good answer for your patients quickly.
And the other thing, a take-home point is, how do we know all this stuff? Well, we've tried and failed with corticosteroids, with orthobiologics, with looking at tendons. And it's about seeing these patients come back and why did this patient not respond and why did that patient respond? You have the advantage if you haven't started minimally invasive tenotomy yet, attending these lectures and listening to things, you can kind of start building your practice off of this. But we know this stuff because we've seen it, we've tried it, and it's failed. And we've asked the question why and worked together to figure that out. So just start treating, start looking at tendons, start treating tendons, and see who responds and who doesn't, and pepper, people with questions, your colleagues with questions as to why or why not. Always ask.
If there are any other questions, there's a booth at AMSSM, booth 220. We'll have TenJet representatives. I'm sure would love to talk to you about implementing this, about the utilization for this, about how you can grow that part of your practice. It's very easy to suddenly become the chronic tendon disease guy in a group or girl in a group in an area, right? You start treating patients that everybody else isn't getting better, and all of a sudden it's going to be, well, I don't know what this person's doing, but you should go see them because they're our person, right? This is our doc that we use for this. And as Chris indicated, it's easy to get booked out 4 or 5, 6 months to do a procedure because you're treating people that no one else is getting better.
Yeah, you want to do this. You want to do this procedure from the standpoint of it's a completely different practice, and it's something that no one else wants to take care of. And the three of us would do this for the rest of our career. I mean, this is just, it is satisfying, it's rewarding, it's making patients better. And you'll be the person that someone says, I've gone everywhere, I've done everything, and I need you to help me. And you have something to do. You have something to treat them with that no one else has, right? And that unique opportunity you shouldn't squander. You're highly trained, you're very specialized in this, and there is not another group of providers who can treat patients in this way. So take advantage of that.
Anybody, Dom, Chris, anybody have anything else they want to add before that I've missed, or anybody want to talk about before we presumably wrap things up here? I know we went a little over, and I'll apologize for that. But as you can see, the three of us get excited about talking about this, get excited about our experience with it. We can't have a phone discussion that doesn't unravel in what'd you do today, what'd you do over here, how'd you treat this, and what else can I do with it? Somebody wanted, I saw it came up again, and I missed it the first time, about large Achilles calcifications, and would those be able to be removed? If somebody wants to hit that quickly.
Well, the calcifications, yes, as you saw in the rotator cuff, as you saw in the glute tendon, the calcifications can be removed. If you're talking about, bony projections, osteophytes or enthesophytes, you're not going to be able to bore into the bone and remove the bone. But Achilles calcifications, yes, those would be able to be removed with the TenJet device. Very effective.
I think it's one of the things that you look at and see how much of the calcium is actually causing the pain, right? Because we don't use this term, but if you think of the term a compressive tendinopathy, there's certain areas where tendons can actually get pinched and compressed. So large calcium deposits that are just above like a Haglund's deformity and pushing against the back of a shoe, that's where I would remove them. If they're a little bit higher up in the mid-substance, that calcium deposit might just need to move better with the rest of the tendon. So I've had some that I got in and I wasn't able to get it all, and I was like, it's not going to get any better. And they're like, this thing feels great. And you can just see it's like in the mid-substance, it's able to now move a little bit better. But like ones in the shoulder, that's a complete compressive tendinopathy. There's nowhere for that thing to go. Some of the glutes, when they lay on it, it's gonna hurt. But for some of the other areas, some of the elbows, they only feel it more medial than they do lateral. So more of the medial calcium deposits will hurt them because they're resting it on a chair or on the sill when they're driving.
And then one repeat that I missed is how often do you repeat TenJet or MIT treatment for incomplete response? I've had 2 or 3 experiences where I've done the procedure, gotten a good response, and had both women, both hips, both 3-4 years later came back and said, hey, I think it's back. I think I've got recurrent issues. Women 60s, 70s, didn't rehab afterwards, didn't improve their gluteal strength, had some recurrence of tendinopathy. Both of them elected to do a repeat MIT on the page on the area because their quote was, "It worked great. It was so easy. I absolutely wouldn't do anything else." And both of them I talked into more significant rehab than they did the first time afterwards to hope to keep them there, because I think that was my failure for them, was not getting them better gluteal rehab or pushing the issue more. I think early on patients got better and I didn't push biomechanics as much afterwards as I probably do now. I don't know what you guys' experience with is that either.
Similar. I think it's not been a very high volume that I've repeated. A couple elbows. And I think there's probably a couple people on the call who are a lot smarter than the 3 of us that are going to figure out an entire field of like tenogenomics and figure out what genes it is that cause people to not have like Desmond, to switch back from Aggrecan to Desmond and be able to adhere again. So there's definitely a genetic predisposition. There's people who are tendinopaths. We might have a couple of them on the call, which is why we're interested in it personally. But when it happens to patients, you're going to see it in other parts of their body. So what I would say is, do we repeat them? Sometimes. What I will tell you is a patient who has chronic elbow tendinopathy, it may have chronic patellar tendinopathy, plantar fasciopathy. So there's a lot of patients that we feed back for other parts of their bodies and do TenJet in other parts of their bodies because they can become more symptomatic and they're familiar with it, but not necessarily repeating the same one multiple times.
Yeah, bilateral shoulder calcific tendinopathy, exceptionally common. You do one and somebody comes and goes, I thought the other one wasn't that bad, but I know there's something there. Let's get it out.
Yeah, I'll echo the most common time you're going to repeat it on somebody is a different tendon, a different body part. That happens often. I have frequent flyers for multiple tendons. I see Sunila bumped a question about the TenJet needle being too big for the posterior tib. It is not. I do those frequently. Obviously, posterior tib is, 10% of foot and ankle pain, I guess. So it's not like a huge volume in my practice, not like hips and shoulders and elbows. But the posterior tib is not too big for the TenJet device. Patient positioning is important, and approach is really reasonable. And just getting the cutting window to the area of the tendon is all you really need to worry about. And that's, you only need a few millimeters for that, and you can really get it into place. In terms of damaging the tendon, I think I'm looking back at the chat. You're not going to damage the tendon to the point. I think we kind of hit on that, and that might have been before Dom's presentation, but we're just taking out the degenerative tendon tissue, not the healthy tendon tissue. So you do not have to worry about compromising that posterior tib and causing,
A good question that I think just popped up too is does TenJet require a back and forth motion like 10x?
Did we lose the sound?
We might have lost a little bit. Can you guys hear me?
Yep.
Oh, sorry. Might have missed it just for a second. I said there's a question that said about the back and forth motion of 10Jet versus 10X. I cut out for a little bit, so I don't know if anybody answered it.
I don't think so. You want to take it, Dom?
Yeah, I mean, and we've talked about this as and Nate, actually, I think you were the one who you might have coined the terms, the pistoning and the twisting. I think we call it like the corkscrew there in the piston technique. So wherever that cutting window is, as both these guys have said, that's where the greatest amount of that suction is. You almost create kind of like this cavitation ball of suction that's around it, but really the open part of that window is where it's going to feed in. So you want to take whatever motion it takes to get that cutting window kind of opened up. So think of it almost kind of like a lighthouse, and the light from the lighthouse has to hit all the areas in order for you to feel that you've resected it. So one of the reasons, and what you might be relating to if you're a 10x user that doesn't use TenJet, the back and forth motion that you have to use with 10x is sometimes because it gets clogged. So you have to keep stepping on the pedal and kind of moving it in and out so that you get whatever's occluding the end of it. That's one of the reasons why you have to move the 10x device back and forth so much.
And I have never clogged a TenJet device. I don't know if either of you guys have, but
Not even with a huge calcification.
Right.
But I will echo what you said, and I was trying to jump in there on the posterior tib. Similar size-wise, you get this in a long head biceps tendon and a shoulder too without difficulty. You don't have to worry about size there. And so, if you can take the cutting window to the pathologic tissue, you're in good shape. So that there's a discussion about the 10 or 10Jet settings, and then runtime, right? Talking about different settings for
it's a good question.
And run times. Great question, Chris. You're an experienced user at both. If you want to take that.
Yeah, so I'll just say we probably all for our TenJets have different kind of preferences and run times and all that type of stuff. I basically will debride the tissue until I feel that it's done. Usually you hang a bag of saline. I hang a liter and usually use about 500 to maybe 750 cc's of that bag, maybe 500 or so. I always hang a liter bag though. That ends up being a couple minutes of run time or cut time for the 10Jet device. There's settings, I guess you'd call them power settings. I usually set mine on about 7, 1 to 10. I think the settings run. I don't really go less than 6 or 7. I go up to 10 for certain other things that I'm using this for that require a little bit more negative suction. But I'm usually sitting about 7 or so for my power on the device. So about a 500 cc bag of saline, 7 cc or 7 on the power on the device. It usually lasts it's usually 3 or 4 minutes, less than 5 minutes for procedure time.
Great. And somebody asked about always going in long axis to the tendon. I mean, that's the best way to see where you're at, but not always. I'll do things in short axis. on an Achilles, or I mean on a plantar fascia, I'll switch back and forth between long axis and short axis to orient myself. It is certainly doable both ways. Early on, I think for comfort, it's easiest to see the plane of what you're working on in long axis. As you develop skills, a lot of people find it's easy to work in short axis, finding your needle tip and working through it. I don't think there's a set answer to that. And I think frequently a lot of us will cycle back and forth to orient ourselves and see tissues that we're working at.
Yeah, agreed. The video that's up here is just one of the ways that some of us approach the Achilles tendon. So instead of trying to come longitudinal in plane to an Achilles tendon where you're going to get stuck in some really healthy tissue and you're going to be driving from the back and kind of forcing through some of that tissue, coming transverse in plane and then flipping back to your longitudinal out of plane like this, you're able to sweep the device up and down the Achilles tendon. So the right approach is the approach that allows you to access the most amount of tendinosis, regardless if that's in plane or out of plane. So being able to make sure that you can actually reach the tendinosis is the right plane to be in.
Yeah, hey, it's a great video of, and we've talked about this recently, and kind of utilizing that device in that soft tissue plane to kind of strip the tendon as you go. As Dom indicated, a lot of those nerve sensation fibers in that tissue layer and kind of getting in there and hydrodissecting it and freeing it up, I think can help definitely with pain as well. And then there was a question that any harm in cutting too long, since this is selective, or power setting specifically. I think it's very good reproducible safety data that's been out on no, right? This is not going to harm healthy tissue. You can crank it up and run it, and it's not going to harm any tissue that you're worried about. We all have slightly different preferences on run settings, but there's some standardizations, but you don't have to worry that you're going to cause harm regardless of your setting choices.
Yeah, agreed. 10x had the settings that the runtime for 10x was mainly when it was going to get too hot. Normally I was looking, I was like, it could have counted down the other way to when it was going to get so hot that I pulled it out. Right. Not to pile on for it. It's just, they're two very different. I mean, there were a lot of questions before about it. They're completely different devices. They're not the same devices.
Yeah. And I knew when I was done, when it hurt my hand, right? I'm starting to get too much heat in my own hand. And then to use Tendet to hydrodissect the peritendinous fascial plane, or only use your local anesthetic for it. I do both. After much discussion with you guys, I always have hydrodissected initially. I think it really helps tissue delineation. I do think it helps with hydrodissection for some nerve pain associated. But then I now like to guide my device through that same tissue plane, run it through there as I'm doing it as well. And I think there's a benefit to that. And I've seen some improvement afterwards as well.
Yeah, same thing with like a bursa, right? Like when you're doing a supraspinatus and then you're looking at the bursa, a lot of those bursas, even after you hydrodissected, both sides of the bursa, so the underside of the deltoid and then the superior side of the supraspinatus, those bursas, when you look at some of those that have been chronically inflamed, it's almost like in like small little interdigitations that they'll have, like these big fluffy kind of chunks that are in there because of chronic inflammation, and again probably some underlying undiagnosed autoimmune that causes like this synovitis almost type of inflammation in the bursa. So using that device to almost kind of clear that down and decrease and decompress it. Certainly there's more pain producing lesions than just the tendon, so the fascia, the bursa, all of these tissues that you're able to get in and be able to debride. I know the cool thing about HydroCision, they've been very open to, and specifically Elaine and Sneal have been open to saying, hey, where can we use this? Where does it make sense? And innovative company that's very open in for feedback from their users and engaging in conversation. So there's a whole field in front of us of treating tendinopathy that we're just scratching the surface of.
Yeah, and if you look at those arthroscopically, if you've ever seen some of those arthroscopic bursals, they are leathery. You know, the arthroscopic surgeons will often just lavage the heck out of them as they go, and you know they'll believe there's a benefit to that, and you can just see them. And this will really, it's something I'll do frequently concomitantly with the tenotomy that I'm doing.
Yeah, and it doesn't take you really that much extra time. You're on your way in. You're just going to do it anyway. So. Yeah, one of the fun things is the collaboration is touching on with HydroCision and these two gentlemen right here that are fun to talk to and fun to learn from. it's time for you guys to, pick up device and start treating these tendons and join the conversation, and we can all learn from each other. That's the great thing about this specialty, is we can be collaborative and learn from each other, but you got to start treating so we can pick your brain too.
Yeah, and the more you do, the more you're going to start to think about applications of other than basic, right? Other than I'm doing a glute tendinopathy, or I'm going to do a lateral epicondyle. It starts to become, what can I fix with this thing? What other problem that nobody can get better am I going to be able to treat? Because a tendon's a tendon, right? Tendons behave like tendons. Tendons get disease like tendons. I don't care if you're doing a posterior tib, you're doing a lateral epicondyle, you're working a long head of a biceps, you're doing some crazy stuff in the lab that Dom's doing down or over there. It's just, tendons behave like tendons. Pathology is pathology. Use the device to treat the problem. Any other questions? Anything you guys want to add before we? If MRIs miss gluteal tendinopathy and the ultrasound can't image it properly because of patient size, have you ever tried a TENJet? Yeah, I mean, if they're if they're heavy enough, I think with a curvilinear probe and leaning into it, and sometimes I'll put my full body weight on somebody, I can usually see what I want to look at. It's tougher. There's a challenge there. Sometimes, as we indicate, that's a patient that's easier to do in short axis to reach it. I've done some people that you have been pushing the limits of the when I was using the OR table. Now I'm just doing them straight on the gurney, but pushing the limits of the weight limit for the ASC for sure. And you can get there. And if you're confident that you know what the tissue pathology is, I think that's perfectly appropriate, because you're going to use that in that scenario to go in and evacuate and lavage that bursa. You're going to use it to delineate the tissue. You're going to feel that tissue tactile feedback different when you're doing your local. When I'll use even just a steroid injection when I'm still doing them to try to feel the same thing, to try to get tactile feedback and utilize it. And if everything fits in the box, it's not something I'm afraid of doing for sure.
Yeah, and it's all about, we have our Hippocratic oath. We first want to do no harm, so we don't want to harm a patient. Thankfully, this procedure has not a lot of negative aspects to it in terms of damaging healthy tissue and things like that. So if you want to treat something that you're not quite sure is tendinopathic, but maybe looks or smells like it, but you can't quite know, you treat it and see what happens. Most of the time, not every time, not everything's 100%, but most of the time they're going to get better, and then you gain your confidence that way. So yeah, there really is. There's one of the nice things about this device is I am very confident that I'm not going to cause harm in a patient by utilizing it for tendon treatments and otherwise. So yeah.
Yeah. And Bilal, with the patient that you described right there, you've already done an MRI. You know that there's not something else that's causing the pain. Even if you can't see it on the ultrasound and you don't see like a significant amount of tendinosis on the MRI, you at least know that they don't have a stress fracture. It's probably not their hip. You've ruled out everything else. They have atraumatic non-radicular lateral hip pain. What else is it? It's gluteal tendinopathy, right?
Yep.
And it's going to be tendinosis. And so getting in there and treating it, I agree with both of the guys. I mean, you'll look great every single time when everybody else has kind of pushed this patient off and said, "Hey, you're too big. You need to lose weight. You need to do this. You just need to get your glutes stronger." You go in and do a diagnostic injection, and they feel great, even if it's just anesthetic, right? And they're like, "Yeah, that took it away for a couple hours. Great, let's go to TENJet then." Right? I mean, there's nothing else that's causing your pain.
Yeah, that's a great point. Utilizing that diagnostic injection if you're not quite sure. That's a great predictor of the pain generator, and we can do that with our ultrasound. So yeah, that's a great point, Dom. Don't forget, if you're confused or the diagnostic testing is inconclusive and you're not sure, numb it up and see if it gives them pain relief.
Yeah,
you are the only people who can take. We are the only people who can take care of that patient.
Yeah, same answer. Like, we use diagnostic injections for all sorts of stuff, right? You got a patient with shoulder tendinopathy and some radiculopathy, and you're going, how much is coming from where? My go-to is a diagnostic lidocaine injection and say, how much better do you feel, right? So I utilize those all the time, especially if there's any question. If you're not 100% certain, a nice diagnostic lidocaine injection will help you feel tissue planes. It'll help you feel tissue pathology tactily, and your patient gets better. You're at the source of their pain. You guys have anything else to add? I think we've exhausted all the questions. My take home is you should be doing this. It should be in your toolbox. As soon as you get it in your toolbox, it'll become more a go-to utilization procedure for you when you start getting patients better that you weren't getting better before.
Yeah, I agree. And don't be afraid. Just start treating patients. You know more than you think. We can do more than we're already doing as a specialty as a whole. And like we said multiple times before, these are our patients. We need to champion their recovery, their treatment, and their successful outcomes. So pick up a device and start treating.
You use the decade of experience that we've had doing this wrong to get to this point. Lean on your colleagues, and we're here to reach out to if you have additional questions going forward. We do this as a community because that's what we do at sports. Sports is a team. Medicine is a team sport, and we're part of the team. So, Elaine, Sunil, any closing thoughts?
Well, first of all, thank you for everybody for the input, for the questions. We went way over time, and we're pretty excited about it because it means there's value. So thank you very, very much. And don't hesitate. If anyone here has additional questions, wake up tomorrow morning, you have a question, reach out to us, and we'll put you in contact with these gentlemen who are very generous with their time. And otherwise, as mentioned before, if you happen to be at AMSSM, we'll be there, and we're happy to entertain any questions you have. I know there was a question on reimbursement. I didn't want to exactly write a diatribe, so we can tackle that face to face. Thank you very much.
An engagement, and I'm happy to get involved in more discussion with anybody that wants to have it. Obviously, all three of us seem passionate about this because we see the value, and we see where you can help people, where we're helping people. And honestly, we need your help. We got a backlog of patients, and we need to get them in, and you can do them too.
Awesome. Thank you.
All right. Thank you.
Thanks, everyone. Thanks for the questions. Have a good night.
Bye-bye.